هنبتدي النهارده السيشن بودي ايميجينج سيشن. طبعا انا معانا الاستاذ الدكتور طارق الدياسطي، استاذ بجامعه المنصوره ومركز الكلى ورئيس جمعيه الاشعه وغني عن التعريف، وطبعا سعداء بحضوره معانا، وزملائي الاساتذه دكتوره اماني رشاد والدكتور عبير عبد المقصود، وفي انتظار طبعا حضور باقي الاساتذه. اول حاله هيقدمها الدكتور طارق.
Good morning, dear colleagues. It's my pleasure to be here with you, and I'd like to thank all the organizers for their kind invitation. We'll start the first session of the second day, body imaging session. First speaker is Dr. Sherihan Madkour. She will talk about imaging of gallbladder perforation. Please, Dr. Sherihan.
Good morning, Professor and colleague. Today we will speak about imaging of gallbladder perforation. Objectives: causes of gallbladder perforation, pathogenesis of gallbladder perforation, classification, image finding and differential diagnosis. Acute cholecystitis is the most common cause of acute pain in the right upper quadrant. Is a common cause of hospital admission, can be calcular or acalcular. Complication of acute cholecystitis: perforation, fistula formation to the duodenum, either passage of a stone to small bowel where it gets stuck and cause what is called gallstone ileus, or the stone stuck at the duodenum secondary to fibrosis cause what is called Bouvert syndrome. Causes of gallbladder perforation: either spontaneous, which is idiopathic, or secondary to gallstone, cholecystitis, trauma, neoplasm, steroid use, or vascular compromise, iatrogenic, traumatic. Pathogenesis of gallbladder perforation: gallstone impacted in Hartmann pouch or cystic duct cause increased intraluminal pressure, edematous gallbladder wall, gallbladder distension, which lead to vascular compromise, wall necrosis, and perforation. Symptom of gallbladder perforation can range from benign non-specific abdominal symptom to acute generalized peritonitis. The perforation cannot differentiate it from uncomplicated acute cholecystitis. Nimier classification of gallbladder perforation: type 1, acute free perforation; type 2, subacute pericholecystic abscess; type 3, chronic cholecystoenteric fistula; type 4, cholecystobiliary fistula formation. Complications: bile peritonitis, hepatic abscess, subhepatic abscess, pelvic abscess, pneumonia, pancreatitis. Treatment: pericutaneous cholecystostomy, intravenous antibiotic volume resuscitation, cholecystectomy is performed. Case 1, 61-year-old male presented with right hypochondrial pain. CT image reveal gallbladder show thick edematous wall, it mucosa show interrupted hyperenhancement with focal discontinuity, yet intact serosa, suggestive of intramural perforation. A hyperdense stone is seen at the gallbladder neck. Case 2, 49-year-old female, not diabetic, complaining of pain increasing in praying position. Labs reveal elevated serum amylase and lipase. CT and MRCP is recommended to exclude necrotizing pancreatitis. CT image reveal gallbladder lateral wall defect, stone seen adherent to wall, subhepatic pelvic paracolic high density fluid collection, bilateral pneumonic patch. The patient already have liver cirrhosis with portosystemic collateral and ascites. MRCP confirms the previous mentioned finding. Diagnosis: acute gallbladder free perforation, Nimier type 1, complicated with pneumonia and biliary peritonitis. Treatment: ICU admission is the patient have hepatic encephalopathy, intravenous antibiotic, then cholecystectomy. Case 3, 60-year-old female presented with jaundice, vomiting, passing dark urine, and clay stone. Ultrasound reveal acute cholecystitis with impacted stone at the neck. MRCP axial T2 image reveal gallstone. Coronal image reveal defect at the fundus, communicating with subhepatic localized collection. 3D image reveal gallbladder perforation, communicating with subhepatic collection. Diagnosis: gallbladder perforation, Nemeyer type 2 with subhepatic collection. Treatment: cholecystectomy. Case 4, 52-year-old female, did CT-UT prior to renal biopsy, accidental discover gallbladder contracted over multiple stone with ill definition of the wall of its fundus. Gallbladder wall seen adherent to the anterior abdominal wall, related to localized high-density fluid collection, which is seen communicating with another left lumbar collection. Another pelvic collection is noted. Diagnosis: gallbladder perforation with anterior abdominal wall, left lumbar, and pelvic collection. Treatment: antibiotic and cholecystectomy. Case 5, 69-year-old female presented with symptom of intestinal obstruction proven by X-ray study. CT reveal contracted gallbladder over stones, small bowel intestinal obstruction, down to stone seen at distal ileum. Diagnosis: gallstone ileus secondary to cholecystoduodenal fistula. Treatment: cholecystectomy with anterolysotomy and repair of choledocho enteric fistula. Case 6, 80-year-old female presented with bleeding per rectum of 1 week duration. Examination revealed generalized abdominal tenderness and rigidity. CT reveal air foci within gallbladder with duodenum closely related to its wall. Dilated ileal bowel loop, down to stone at the distal ileum. MRCP revealed moderate to marked intrahepatic biliradical dilatation, defect between medial wall of gallbladder and lateral wall of duodenum. Diagnosis: gallstone ileus secondary to cholecystoduodenal fistula. Differential diagnosis include gallbladder empyema, gangrenous cholecystitis, emphysematous cholecystitis, subhepatic appendicitis. Regarding gallbladder empyema, CT revealed distended gallbladder with high-density material, show internal septation with irregular enhancing intact wall and smudging of surrounding fat plane. Emphysematous cholecystitis, the gallbladder is distended and there is air identified within its wall. Air also seen in the intrahepatic biliary duct. Gangrenous cholecystitis, the gallbladder is distended, show thick wall with sloughed membrane. In this case, cholecystostomy tube is seen in situ. Gangrenous cholecystitis show no enhancement of wall in post-contrast phases. Subhepatic appendicitis, 38-year-old female complaining of fever, epigastric pain, and right hypochondrial pain with marked elevated total leukocytic count. The clinician suspected gangrenous cholecystitis. CT reveal normal gallbladder, distended subhepatic appendix with smudging of fat plane and related lymph node. Diagnosis: subhepatic appendicitis. Treatment: appendectomy. Take-home message: gallbladder perforation are a serious complication of acute cholecystitis and represent an advanced stage of the disease. They tend to occur in an elderly and/or comorbid demographic and carry high rate of morbidity and mortality. Symptom and the clinical sign are variable and can range from benign non-specific abdominal symptom to acute generalized peritonitis. Gallbladder perforation may be initially treated by percutaneous cholecystostomy. Patients typically require intravenous antibiotic, volume resuscitation, and close monitor in an intensive care unit, then cholecystectomy. Thank you.
Thank you, Dr.